Hi, my name is Sahanashree Rajeshkumar and I go to Robbinsville High School. Today I'm diving into the health disparities and endometrial cancer among Black women, a crisis that's often overlooked, but it has devastating and preventable consequences. So a little bit about me. I'm a junior at RHS in New Jersey, and I'm passionate about tackling health disparities in medicine, especially in cancer care. Outside of research, I play on my school's tennis team and coach at the Princeton tennis program. I also volunteer at RWJ Hospital, where I've worked across several departments and currently help with a mammography unit with patient prep and imaging data during screenings. I was awarded the Most Outstanding Research Associate Scholarship with the Teen Think Tank Project for my work on mental health equity, and now I'm working with researchers from Princeton and Cold Spring Harbor Lab on a project called MindEye and exploring how we can reconstruct what the brain sees in real time using MRI data. Long term, I hope to become a pediatric oncologist, combining research, care, and advocacy. And what excites me most about today's talk is that this isn't just theory. My team and I worked with real data, uncovering the deadly disparities in cancer care that too often go ignored. Let me start with a simple question. How many of you have actually heard of endometrial cancer? It's the most common gynecologic cancer in developed countries, but here's what shocked us. Black women are 66% less likely to be diagnosed with it than white women. At first, that might sound like good news, but it's not. Despite being diagnosed less, Black women are twice as likely to die from it. That's not just a statistic, that's a crisis. Fewer diagnoses, yet more deaths. Something is seriously broken. And this isn't just an American issue. We looked at data from both the United States and the United Kingdom, two completely different healthcare systems, one insurance-based and one universal, but the same disparities showed up in both. So we can't blame the lack of insurance. This points to something much deeper, something embedded in the structure of how we deliver care and who we listen to. It's systemic. So to understand what's really driving this disparity, our team, 9 researchers in total, conducted a systemic review. We analyzed a major study we could find between 2013 and 2023 that examined endometrial cancer and racial disparities. We didn't just want to confirm the problem, we wanted to find out why it was happening. So we focused on 3 core drivers: social judgments of health, healthcare accessibility, and financial barriers. By approaching it from multiple angles, we were able to not only find patterns, but causes. So what we found were 3 major barriers that explain why outcomes for Black women are so much worse. First, access. Even in the Department of Defense healthcare system, where access is equalized across all patients, Black women still had significantly worse outcomes. This tells us that access alone doesn't guarantee equitable care. Equal access isn't the same as equal outcomes, because if the system itself is biased, it doesn't matter who gets in the door. Second, financial barriers. Income plays a huge role. Women earning between $35,000 and $50,000 had a 65% lower rate of developing endometrial cancer compared to women earning under $15,000. That's a massive gap. But even with insurance, Black women face higher denial rates. Our review found that 2.04% of claims from Black women were denied, compared to just 1.13% for white women. That might sound like a small number, but when you apply to thousands of patients, it means thousands of more delays and thousands of more people falling through the cracks. Third is communication. In a UK study with over 700 women, Black women were significantly more likely to feel embarrassed or hesitant when discussing symptoms with their doctors. That delay in conversation leads to a delay in diagnosis and treatment. If someone doesn't feel safe or heard in a clinical setting, they're not going to speak up until it's too late. Even when Black women are diagnosed, they face treatment delays, on average 4.2 days later than white women. That might sound small, but in oncology, every day matters. A few days can be the difference between early stage treatment and a more aggressive late stage battle. And it gets worse. Our research revealed something deeply concerning: sampling bias. Many national databases systemically underreport the most severe or fatal cases involving Black patients. That means the data we use to make decisions is already incomplete. So if the numbers we do see are already alarming, the true scope of the disparity is likely much worse than we think. But our research didn't stop at identifying the problem. We also looked at what's working. The most promising approach we found is something called community-based participatory research. These are programs developed with communities, not just for them. They led to a 30% increase in preventative care usage in minority populations. So it's a really life-saving solution. We also found that hospitals that implemented implicit bias training saw an 18% drop in racial gaps in both patient satisfaction and adherence to treatment. That tells us that bias isn't just an abstract concept, it directly affects how patients experience care and whether they follow through. And finally, personalized treatment plans. When care is tailored to a patient's genetic background, cultural context, and environmental factors, outcomes and trust both improve. So the takeaway here is simple. Equity doesn't mean treating everyone the same. It means giving each person the care they actually need to survive. So what do we do with all of this? First, we need system-level reforms, expanding Medicaid coverage, embedding social workers into care teams, and standardizing treatment protocols so they're less vulnerable to individual bias. Second, we need targeted policy changes. Our data showed that low-income patients, especially Black women, face higher denial rates. Streamlining approval processes and ensuring fair coverage across income brackets is key. And third, this is big, we need more research. Our project took months and a team of 9 just to scratch the surface. So imagine what could happen with proper funding, larger data sets, and a national commitment to studying disparities. Most importantly, we need to stop acting like these outcomes are inevitable, because they're not. Every disparity we've uncovered is rooted in something fixable. So the question isn't whether we can fix it, it's will we. Health equity isn't optional, it's a human right. The disparities we found in endometrial cancer are part of a much bigger pattern, but the difference is we have the data and we know what works. So whether you're going into medicine, research, policy, or advocacy, you have a role in making sure that race never determines who survives and who doesn't, so we can eliminate these disparities. So these are the key references that grounded our research, from national cancer registries to systemic reviews. Each one contributed critical insight into the disparities we identified and the solutions we explored. I want to say thank you to my amazing team, especially Nicole Photo in particular for her mentorship and support throughout this process. We're also incredibly grateful to the institutions that gave us access to the data we needed, and above all, this work is dedicated to the Black women and families affected by endometrial cancer. Their experiences are the reason that this research even matters. So if you're interested in learning more, collaborating, or just talking about health equity, I would love to connect. You can reach me by email, find me on LinkedIn, or read the full research paper on ResearchGate. And of course, if you have any questions, I'm happy to answer them. So thank you for your attention, and thank you to GHLC for this platform to share this clinical research.